Hi, I'm Dr. Mark Student, and I'd like to welcome you to Cairo Secure's presentation today. And I'd like to thank them for having me here today to be able to share this information with you. I'm very, very, very excited to do so. So before we get started, I just want to let you know that I live in the apolitical world. This is not about politics. It's not about ACA, ICA, WCA, no CA, this CA. It's about the science. It's about having a patient-centered approach to healthcare. And it's about providing quality healthcare in a safe environment where the doctor doesn't guess. And to me, that's the most important thing. So with that being said, let's get right to the presentation. The question at hand today is x-rays and clinical chiropractic. Are they safe? Are they needed? I mean, when do you use an x-ray? And there's been a lot of controversy out there, but really the science answers the controversy. And knowing what's going on with your patients is always paramount. Now, never forget, there are three parameters that we live our life by: diagnosis, prognosis, and treatment plan. It starts with an accurate diagnosis. Then you prognose your patient, can you help them? And then if you can, what's the treatment plan? And in order to do that, there needs not be any guessing involved. None. Zero, zip, not a zilch, niet, gunish, no matter what language you put it in. There can never be guessing in what you do. But the only thing I want to share with you is when you order a test, whether it be an x-ray, an MRI, no matter what it is, it has to affect your treatment plan or your prognosis. If it doesn't affect your prognosis or treatment plan, what's the purpose of doing it? You just don't do it. If you're in a medical legal world to make a lawyer happy, that's the last reason you do it. But you don't not do it because you'll anger an insurance company. Those aren't reasons to or not to do something. So when you do a test, there always has to be an order. And having an order is critical. And when you order x-rays, it's a form of treatment. So there must be a treatment order for everything you do, and x-rays are no different for everything. And don't think I didn't treat my patients because I didn't adjust them. Well, that's absurd. If you're rendering an opinion, you've treated them. Think about a surgeon. They walk in, they don't do surgery, but yet the surgeon is treating them. He's managing their case. And you have to be a case manager. So when you're managing your case, it starts with a complete history, examination, and if it's clinically indicated, then x-rays are important and you need an order. You need a treatment order. Think about the go into an emergency room. You go into the ER, you see the triage nurse, then you go into the doctor who evaluates you. He might order an x-ray, he'll write it down. Then you go to the radiologist or the x-ray tech. They'll take the x-ray, the radiologist writes a report, sends it back to the ordering doctor with the report, and now that circle's complete. Just because you do x-rays in your office doesn't insulate you from that process. You see a patient, you're going to do a test, you're going to do a treatment, anything you do. There needs to be an order and a clinical rationale. And for me, the clinical rationale for x-ray is always to determine, based upon my examination, if there is either anatomical or biomechanical pathology. And that's critical because those are the two things we're looking for: anatomical, fracture, tumor, infection, or a spinal biomechanical pathology, which we'll get to in just a moment. Now, I'm going to do a little bit of reading right now, okay? And this is important to understand of how you're being looked at from a perspective of looking at an algorithm of the frequency of how much you order things, do things, and change things. This is from the carrier side. And this is actually from a federal complaint, a RICO complaint against the doctor down in Florida in July 2020. And let's do a little bit of reading. ABC Chiropractic ordered x-rays, took x-rays on the site. Further, despite the patient population having diverse x-ray findings, the results of the x-rays did not impact the patient's course of treatment. There was no change in diagnosis or prognosis. The change in the treatment plan, when it occurred at all, was almost always limited to a standard decrease in treatment frequency rather than an amended and individualized treatment plan based on x-rays findings. Now, Here's my comment. And by the way, this was published in the American Chiropractor, this article, about a year ago. So you're more than welcome to contact me. I'll get a copy of the article to you. But here's the comment. The carrier contends there was no change in care, yet a reduction in dosage or frequency was ordered as a result of repeat imaging, which is a change in the treatment plan. However, if you leave it to the carrier to decide why you reduce the care, you are leaving yourself exposed. This is defensible with a straightforward explanation in your records. Secondly, when providing self-ordered x-rays within a doctor of chiropractic's clinic, there must be a treatment order for those x-rays stating why they are being ordered before taking the x-ray. Your E&M report, your evaluation or reevaluation, evaluation and management, that's an E&M, is not a de facto treatment order, and you must treat this order just like the one that's going to an outside facility that you do not own. In the clinical note, you must indicate both why the x-rays are being prescribed and afterwards, if and how the x-rays changed either your diagnosis, prognosis, and treatment plan. This includes confirmation of your original clinical conclusions. And that's really important to understand. I took x-rays, the listings changed. I took x-rays, there's no fracture, tumor, infection. There's, all these things change what you do. So what you're going to look at, and for a reason, and I spoke about this a moment ago, you need either an anatomical pathology, anatomy, fracture, tumor, infection, change in tissue structure or composition. Anything where you think might be there is a reason. Secondly, spinal biomechanical pathology, abnormal osseous location. That's spinal biomechanical pathology. Anything that's a precursor to Wolff's Law. And Wolff's Law says a bone that's in aberrant position will remodel that bone. In other words, it'll create arthritis. And Julius Wolff coined that about 1850, 1860, even before x-rays were invented in 1895. So they knew that abnormal positioning vertebra, ankles, knees, anything, if there's abnormal pressure, the bone's going to remodel. Anytime you have vertebral, and this is related to the spine or pelvis, anytime you have vertebral motor unit deviation, well, that's abnormal biomechanical pathology. Pelvic deviation, abnormal biomechanic pathology. You are diagnosing pathology, and that's a reason for ordering x-ray. Now, let's look. This is something every chiropractor in the world is taught. Spinal biomechanical pathology. We're taught, if you look at the ChiroTouch's report here, C3, posterior on the right. T1, posterior left and inferior. T2, it's antero. T8 is retro. These are listings. This is biomechanical pathology. And you need to understand this. So if we look at even one step further and you look at a pelvis, ASIN on the right, PIEX on the left. This is standard. Every single chiropractor in the nation is taught this. In the world, not just the nation. It's just integral to our training. We are all spinal biomechanists. We've all been trained in that, and we all understand it. But the question is, how do you know what's going? Why do you think in school you spend so many years with x-ray posology, osseous pathology, and understanding all of these things? You're not just bone schleppers, okay? You're not. You're not just there to move a bone, play the piano, go up and down. You need specific listings. You need to know what the lesions are. What are the primary lesions? Is it compensation? What else is going on? Is there degeneration there? There's a lot of issues going on that we need to know. Now, let's take me for an example. Okay, well, let's just go before me. We'll get to me in a moment. Let's take visual assessment, because they say, oh, I'm going to visualize what's going on. And you look at postural assessment. Well, let's go to the literature. Fedoruk et al. In 2003 reported visual assessment has shown that, this study has shown that visual assessment of cervical and lumbar lordosis is unreliable. The tool, as visual assessment, only has fair inter-rater reliability and poor intra-rater reliability. Visual assessment of spinal posture was previously shown to be inaccurate. And this study has demonstrated that reliability is poor, and I give you the citation on the bottom. Now let's go to motion palpation. Now that's a little bit different and a little dicey, but you've got to look at the literature as far as what you consider or I would consider acceptable. Holton 2017 reported, and again the citation is on the bottom, there was a high level of inter-examiner reliability, but that only reflected 54.3% agreement between two doctors in one study. Half agreed, half. Now, there was a limitation in the study because there were no x-rays to support the conclusion. Two doctors agreed, but then they turned around and said, well, we don't have x-rays. We don't even know if they're right. But they only agreed on 54% of the time. So to me, half being right, I mean, let's face it. If you went to a surgeon and the surgeon said, gee, Mark, I think that I know exactly where that brain tumor is, the lesion, and it's sitting somewhere, maybe in the cerebellum, maybe somewhere in the pons, but you know what? 54% of the time I get it right. I'm ready to carve your brain up. You know what you're going to say? You're going to tell him to put it where the sun don't shine. You're going to run out and go, that guy's an idiot. And that would be correct. I mean, it's absurd to think that 54.3% is acceptable as a high level of inter-examiner reliability when in fact there was no image to conclude it. So from my perspective, motion palpation is not very reliable. Now, let's take me. This was, well, that's x-rays. I didn't get to me, and I keep trying to jump ahead to me. Let's look at x-rays. In contrast, the reliability of x-ray morphology measurement and biomechanics have been determined accurate and reproducible in both chiropractic and medical specialties. Additionally, O'Hara et al. Reported the assessment of sagittal alignment of the spine is important in clinical and research settings, and it is known that the alignment affects the distribution of load on the discs. That goes back to Wolff's Law, folks. Okay, and the two citations are on the bottom. But the issue is x-rays. You know it, I know it, and everyone knows it, is accurate. It is the only way to come up with an accurate biomechanical assessment of where you're going to adjust your patient. And if you like to use the word manipulate, I don't, because PTs, osteopaths manipulate, chiropractors are all that to adjust. It's not a philosophical issue. It's just a statement which is factual. But when I adjust my patient, I like to know where. Now, we're going to get to my patient now. This was my patient last week. I did motion palpation. First, I visually inspected, then I did motion palpation. And it revealed, the motion palpation revealed spinous left, but the correct vector, the spinous, was much further right than left. So in other words, the vector was right to left. I thought I had to go left to right. I had it backwards, and I didn't know the comorbidity, as you can see in this image, of fusion. I had it backwards. I thought they were spinous left when I moved them. I'm spinous right, I apologize. Because when I moved them, they didn't move too well, and the spinous was right there. And I said, my God, you know what? I could break up that fixation. Thank God. And by the way, I would have hurt that patient. And I'm in the game over 40 years. And I am really good at palpating. I am really good at motion palpation. But I would have got it wrong should I not have x-rayed this patient. And by the way, I don't have to take the x-rays. I can refer out for x-rays. But you know what? I didn't know. I had no clue. I would have hurt this patient. Now, if you take another case that I had, by the way, every single week, and I work with doctors in 49 different states, I get multiple calls. Oh, Mark, thank God I took an x-ray. Thank God I took an x-ray. Thank God I took an MRI. This was 2 weeks ago in Georgia. Agenesis of the posterior cervical arch. Now, how crazy is that? And I've had three doctors report to me this past year. This is a 38-year experienced doctor who performed motion palpation and found mild restrictions at C5, 6, and 7. But he always x-rays his patients because he's looking for biomechanical changes, for biomechanical pathology. This was a disaster waiting to happen should he adjusted that patient's atlas and axis. A disaster. And by the way, I know Kairos Secure is sponsoring today. And just to let you know, they never tell me what to talk about. They never give me an agenda. I do whatever I want as long as it's honest, good for the profession. educational and evidence-based in the literature. In other words, I'm not making stuff up because everything I'm sharing with you is evidence-based in the literature. But think about how happy a malpractice carrier is. Because when you x-ray, you're not guessing and you're not hurting people. It's saving them a ton of money. But think about you. If you hurt someone, forget the money that's not yours. You're going to lose years of sleep, depositions, trials, guilt. I mean, think about that. For what purpose? So we're going to get to that purpose in a minute. But when you want to go to advanced spinal biomechanical engineering studies, there is a very specific tool out there called Symverta. And what it does is, on the left, you can see there's bar graphs which show you the level of pathology, the green bar, of what individual vertebrae are aberrantly positioned biomechanically. And then on the right slide up top, you see that bar graph. It tells you with standard of deviations how much each vertebra has moved, so you can look at patterns and you are not guessing. You can determine from this, where's the primary lesion? Where's the secondary lesion? There is no guessing involved. When you're dealing with carriers and they say, well, did it change your treatment plan in the x-ray? Well, sure it did. I'm looking right here and there's a blueprint on the right side of that screen which gives me my primary lesion. And when I re-x-ray the patient, and we'll talk about that in a minute, and the bars and the graphs change, now I'm going to change where I adjust because the primary lesions have changed as the body is compensating or moving back towards homeostasis. That's what you want to go for. And if you have that also tough case, well, you know what? Maybe you're adjusting compensation and you're not adjusting that primary lesion. That, my friends, is critical because don't muck with compensation. Adjust the primary lesion and allow the body to compensate for itself. So the first thing I do is I screen. For me personally, when I'm evaluating for a patient, I'm not screening for pathology unless there's a red flag of which I'm screening for pathology. In other words, if I think there's a fracture, tumor infection, instant x-ray, don't even take a question. And I might even go right to MRI. Not an issue. But I'm screening for biomechanics. The added bonus is looking for pathology. And there is so much more pathology than you can imagine that's being found. Let me read. This is also one of the responses in that lawsuit when they said doctor was using it only for screening issues. Screening in medicine is a strategy used to look for as yet unrecognized condition or risk markers. We do not take x-rays to screen patients. Rather, x-rays are used as a part of a spinal examination that cannot be achieved from a clinical evaluation. So I'm not using it as screening. That's part of my clinical evaluation, okay? Now, approximately 38.4% of men and women will be diagnosed with cancer at some point in time in their lifetime. And that's based upon 2013 to 2015 data. And I do have that census report. It's on the bottom. Okay. What is the risk of treating with a chiropractic spinal adjustment a patient with undiagnosed or diagnosed metastatic cancer or various types of arthritides, aneurysms, osteomyelitis, ankylosing spondylitis, diffused idiopathic skeletal hypertrophy, DISH, osteophytes abutting critical neurological elements, pathological stenosis, medical subluxation, anteropostural and any other condition that can increase the risk of fracture or neurological damage. The risks are numerous. Perhaps these might be acceptable losses for the carriers, but not treating doctors. Routine use of x-ray is a patient-centered approach and is a segmental radiographic analysis based on patient presentation, past medical history, and physical examination findings. Folks, I promise you, not one patient is walking in your office that says, I feel great, take x-rays. They're walking with pain or a problem, and you have to figure out where that lesion is because you don't know. And I have a real hard rule. And it's very easy. Stop guessing and start knowing. It's very simple. Stop guessing and start knowing. Imaging changes your whole diagnosis, prognosis, and treatment plan. Imaging changes it. And it's very, very important to understand. But what you have to do is let the science give you the answer. You got to find out the answer. Should you x-ray, should you not? Are you going to take a political organization's word for it? Are you going to take my opinion for it, whether x-rays are safe or not? I would hope not, okay? You have to look at the scientific method, which starts with observation, a question, hypotheses, experimentation, conclusion, and then results. And with that, let's look at radiation safety with spinal x-rays. And radiation safety is critical. I don't want to radiate the patient. That radiation is cumulative. They're going to get cancer. They're going to get this. They're going to get that. Well, let's look at the science. Okay, it's not who could huff and puff the loudest, and not 15 people on a board in an organization who makes a decision for the entire profession. We're going to let science rule the day. According to Tubiana et al., among humans, and this is 2009, there is no evidence of carcinogenic effect for acute irradiation at doses less than 100 millisieverts. That's for an individual x-ray, and for protracted irradiation doses at less than 500 millisieverts. The American College of Radiology in the February 2020 appropriateness criteria reported adverse health outcomes for radiation doses below 100 millisieverts are not shown by the evidence. In other words, there's no adverse effect in a millisievert is how much radiation is absorbed. So nothing below 100 millisieverts. An individual lumbar x-ray is look on the right, 1.2 millisieverts. 1.2. Cervical and thoracic are less. 1.2. There has never been a study, ever, anything, and by the way, if you're over 100 millisieverts, 1 in 100,000 patients get cancer, over 100 millisieverts. And radiation is not cumulative. That's the science. So, when you look at all this stuff, and you look at the fear and the dogma, the sky is falling. Chicken Little is out there yelling, run, 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 the sky. Let's look at radiation, fear, and dogma versus truth. I just gave you a good part of the truth based upon science. Let's read. Adverse health outcomes for radiation doses below 100 millisieverts this is even a third reference, are not shown by the evidence. The American Association of Physicists in Medicine. Now, the American Board of Internal Medicine, that's internal medical doctors, who failed on musculoskeletal medicine in a study done at Harvard. I think it was 87% failed in a basic competency test of musculoskeletal care, are putting an opinion out about x-ray. But here you have the American Association of Physicists in Medicine. These are the ones who study this issue. Caution that given the lack of scientific consensus about potential health risks from low doses of radiation, predictions of hypothetical cancer incidence and mortality from the use of diagnosis imaging are highly speculative. The AAPM and other radiation protective organizations specifically discourage these predictions of hypothetical harm. Such predictions can lead to sensationalistic stories in the public media. This may lead some patients to fear or refuse safe and appropriate medical imaging to the detriment of the patient. According to Hendy and O'Connor, no prospective epidemiological study with non-radiated control subject has quantitatively demonstrated adverse effects of radiation at doses less than about 100 millisieverts. It goes on and on and on and on and on. The sky isn't falling, folks. You're not going to kill your patients. There is a few research articles that say that low-dose radiation actually prevents cancer. Well, let's look at it this way, and I don't have the literature behind this. This is pure opinion. I have to qualify that. People take vitamin D to prevent cancer, okay? Where does vitamin D come from? The sun, which causes cancer. Let me rephrase that, which causes radiation. which emits, but everything in appropriate doses, and that's the key. But the key here in our offices, chiropractic offices around the country, your X-ray is not going to cause cancer. It's just the bottom line. The literature is very, very clear. Here is a student rule number 1. If you don't know, you don't guess. And I've got a few hard rules that I've come up in my 40-some years in this industry. But if you don't know, you don't guess. Stop laying a patient down and playing the piano. Up and down, just whatever moves, we're going to get moving. No. Find out where the primary lesion is. And you know what? Don't guess. Take an X-ray. Come up with a listing. You were trained how to do that, folks. You were trained how to come up with those listings. And it's really important for you to be very specific about your patient. Now, what I'd like to do in the last 2 minutes that I have right now, before I say thank you so much, and by the way, the speaker next week is going to be Sam Collins from H.J. Ross. Sam, from my perspective, is arguably one of the most knowledgeable people on coding that I've ever worked with in my career. He's just wonderful. But also, and call Sam. You have questions, and he's great. You have a question, he'll always take your phone call. He'll always answer it. But I'd like to talk about very briefly in the last minute I have, because it affects everyone. And it was a recent ruling that came down in Georgia. And it said that a chiropractor was not allowed to opine on MRI because it wasn't in his chiropractic credential, regardless of what other courses he's done. And that seems to be the mantra of the carriers and the latest trend. So, folks, I want to share with you, your continuing education is valuable. It's extremely valuable. So choose carefully what you are doing, what courses you're taking. Does it meet your needs? Is it taught by people in academia with incredible credentials? Because they're looking at the credentials of the people teaching you also. Really carefully think out CE that you're going to do, and does it support the needs of your career? And that's critically important. I could go on forever, but perhaps that'll be a topic for another conversation. But in the meantime, I'd like to again thank ChiroSecure. We look forward to Sam next week, and I look forward to being able to present to you again. Thank you. Have a wonderful day.